see other people. So, Emma, do you want to?
Yeah. Hi, everyone. My name is Emma. I am a second year rheumatology fellow at Duke. I work with Jeffrey, who is also a former fellow. Yeah, I've listened to clinical problem solvers many times before, so it's exciting to now be working on it with you all. So thanks for having me.
Thanks. Yeah, super exciting to work with you, Emma. I think we might be on service next week as well together.
I think
Um,
so. Yeah, we've been
yeah,
on service together before, and it's usually pretty chaotic, but it's always fun and it's always interesting.
awesome. Super excited for this case. So I believe Mark and Miriam, would you guys like to introduce yourself?
Yeah, I start with myself. My name is Mariam. I'm from Pakistan, and I was here for 1 month at Stanford for my clinical observership under the shadowing of Dr. Mark. And I am new to this platform. Like I joined this platform 1 month back, but it was a very, very good platform and very interactive session. I enjoyed every session and every case presentation. And thank you so much, Dr. Mark, for giving me the opportunity to present case here. And I'm super, super excited to present it in front of you. And thank you so much.
Mark, you want to say a few words?
Yeah, I don't want to steal the show from Miriam, but my name's Mark, one of the CP Solvers members. But yeah, it's been so nice getting to know Miriam, who is a rock star over the last month. So I'm really excited for her to present this interesting case that we saw a couple of weeks ago.
And then finally, VJ, who's I believe scribing.
Hello everyone. I am from one of the CP Solvers member from India. Excited to be here for the case.
And then finally, Animal Preet, who's doing teaching points.
Hello, everyone. I'm also one of the CP Solvers Academy members for about 1.5 years now. Looking forward to today's case, excited for what comes next.
All right, amazing. Let's get started.
Okay, so let's get started. Okay, so starting from aliquot 1, our chief concern was 76-year-old male presented with generalized weakness and lower extremity swelling over the past 3 months.
Okay. Emma, do you want, so the way we're gonna do this, Emma, is that we're gonna co-discuss. I'll have you take the crack at it first, and then I'll add anything if there's anything I can think of to add. So why don't you start first with just a chief complaint? What does that do for you?
A lot of, I mean, it could be any number of things. I think in this case, the chronicity, I think, is what stands out most to me. When we think of like swelling and kind of volume, something that's kind of more insidious versus like a sudden onset, I think can help differentiate your differentials. If I think of like acute onset, like leg swelling, I might think of something more along the lines of like heart failure exacerbation versus swelling that's happening over a long period of time. I might think of like nutritional deficiencies, anything that would cause like hypoalbuminemia. I might think of issues with the kidneys that could cause volume overload. And then, generalized weakness is pretty vague. A lot of things can cause weakness. A lot of things can cause fatigue. Obviously, coming from the rheumatology world, when we hear weakness, we think of myositis. But yeah, I think I want to know more about this person before
Yeah.
I say anything else.
Definitely, I completely agree. And I just wanted to highlight one thing that Emma said, which is the chronicity of symptoms. So, most rheumatologic diseases are chronic. So, if we were getting an acute time course, it already is a little bit of a red flag. Maybe this is a mimic of a rheumatologic disease. But given this has been going on for 3 months, certainly rheumatologic things are in the differential. That's the only thing I'm going to highlight. We can continue with the rest of the case.
Okay. So regarding HNPI, the patient was having generalized weakness over the past 3 months, which was present at rest, and he also had difficulty in standing up and walking due to severe weakness. But he denies paresthesias, numbness, and speech issues. And regarding his lower extremity swelling, it was also present over the past 3 months. He noticed worsening edema on his legs with pain around his ankles, especially on the right side, and it was associated with leg cramping that worsens with exertion. Also, he had poor appetite and weight loss of around 10 pounds over the past 3 months. The patient denies any shortness of breath, chest pain, palpitations, orthopnea, cough, and night sweats. He was not having fever, chills, urinary symptoms, or hemoptysis, and any GI symptoms like diarrhea, abdominal pain, and constipation. Also, his past medical history was not known, and also the past home meds were also not known, and his family history was also not known. Regarding his social history, he has not seen a doctor for several years, and he has lived in his car since 2018 and has been traveling around the US. He told us that he stayed with his cousin nearby for a month, a couple of months ago, and one of the interesting finding like about his history is that he told us that he had an existential experience as a teenager and now focuses on the relationship between humans and the surrounding nature. And regarding his accommodation, he always lived in Northern California, but has been to Mexico once a long time ago. And regarding health related behaviors, he denies smoking and alcohol use, and he admits using marijuana every day. And he has no known allergies. And I stop here.
Okay, awesome. Emma, you want to take a crack at what the history, what are your thoughts?
Yeah, I think the weakness with standing up in particular gets, for me at least, I guess, let me back up. When I think about myopathies, if weakness really is the thing we're focusing on, in the rheumatology world, we think about distribution of weakness. And so proximal versus distal, unilateral versus bilateral, and kind of whether it's symmetric or not. Um, and so in this case, when I hear that he has weakness with standing up in addition to walking, I'm thinking about more proximal weakness, at least in the thighs and hip region. And then the 10-pound weight loss, a lot of times in our autoimmune myopathies, there is like a weight loss component, whether that's because it's a perineoplastic process or otherwise. One thing I was kind of hoping to hear was that he was on a statin, which would kind of be, a good giveaway for like a statin-induced myopathy, which does tend, Jeffrey, correct me if I'm wrong, but I feel like statin-induced myopathies do tend to favor kind of proximal lower extremities more than any other muscle group. So the fact that he was, if he hasn't seen a doctor in several years, I have a hard time believing that he was on a statin or at least is taking a statin. Um, so that was something I'm thinking about. But yeah, I mean, in a patient of this age, in terms of a differential for myopathies, certainly like autoimmune, I'm thinking of, in addition to paraneoplastics, I think with his age, that's definitely up there. Something else I would think about. Beyond like a statin-induced myopathy, if he has any kind of remote history, would be inclusion body myositis. Though Jeffrey, you'll have to chime in terms of like exact timeline in terms of when we would anticipate seeing that, if like kind of 3 months fits that time course or not. Because I haven't seen any, at least in fellowship thus far. So that's kind of where I'm at.
Emma, what do you think about and I agree with everything that you said, with the statin and with it being more proximal, usually in the lower more than upper, and all the other things that you're describing about this presentation. The thing I'm interested in is what do you think about this asymmetric the swelling around the ankles with pain worsening on exertion.
Yeah. When I first heard the pain worsening on exertion, I was thinking of like claudication, and whether potentially it, certainly like if you claudication is going to cause you to have that kind of cramping that's worse with exertion just because you're not perfusing the limb as well. And right worse than left, maybe sure, you could have a bilateral, um, blood clots. I guess they'd have to be arterial to have the kind of claudicating symptoms. And certainly, if he has some sort of autoimmune process or autoimmune myopathy going on, he's presumably like pretty inflamed and hypercoagulable because of that. So I guess that was the first thing that came to mind. Um, yeah. How about you? What did you think?
Yeah, I mean, so far I agree with everything you said. We're still trying to figure out where the problem is, and it seems like it's heading towards maybe a myopathy, given that we're being told about weakness, and the weakness is chronic. So this subacute to chronic weakness is definitely something with or without pain, but generally, if you're thinking about a immune-mediated myopathy, if you're having chronic progressive weakness without pain, that is a good, very strong clinical story for an immune-mediated myopathy. It is it is curious. I am very curious about what this swelling is referring to. Is it just, as Emma mentioned, something vascular, like a venous issue or an arterial issue? Or could it be like the patient has inflammatory arthritis there and is thinking that um, is assuming that it's related to something vascular, but the reason that it's worsening is maybe that she's using her joints and it's actual ankle synovitis. And I'm not really sure how I would be able to put that together, like why you would have ankle synovitis in terms of a patient that has a myopathy. But yeah, I'm kind of curious to hear what happens next in the exam, and we'll get to see if that's what's going on. All right, Miriam, let us know.
Okay, so starting with Aligot 3, regarding his vitals, his temperature was normal 98.4, and his heart rate was normal, not normal, like slightly the upper range 96, and his blood pressure was high 140 by 88, and his SpO2 was 95% on room air. Regarding his examination, he was chronically ill appearing and but in not acute distress. Regarding his head and neck and throat examination, it was unremarkable with sclera anecteric and extraocular movements intact. Regarding his cardiovascular examination, he was having tachycardia but with no murmurs, rubs, or gallops. Regarding his pulmonary examination, he was having bibasilar crackles and right lower lobe crackles, but normal work of breathing at room air. And his abdomen was soft, non-tender, non-distended, no rebound or guarding, and no suprapubic tenderness. Regarding his extremities, he was warm, well-perfused extremities and 2+ dorsalis pedis pulses with 3+ pitting edema at lower extremities bilaterally with right lower extremity erythema and calf tenderness. Regarding his neuro examination, he was alert, aware, and oriented with no facial symmetry, with tongue in the midline. Power was 5/5 in upper and lower extremities, and the sensation grossly intact. Regarding his psychological examination, he was having magical and grandiose thinking because he was solitary most of the life and has no strong desire to be with others. And regarding his skin examination, there was no rash. And according to his labs, on CBC, WBC count was normal 9.4 with normal differentials, and hemoglobin was 7.4, MCV was 83, and platelet count was 363. Regarding his chemistry, sodium was 137, and potassium was 7.3, chloride was 105, bicarbonate was 25, creatinine is 10.36, blood urea nitrogen was triple one, and EGFR was 5, anion gap 19, calcium 7.3, and PO4 is 7.4. Regarding his LFTs, total bilirubin was 0.3, AST was 25, which was normal, ALT was 21, again it's normal, and alkaline phosphate was 114. His albumin was 2.1, and coagulation profile was INR 1.2. His CK levels was normal, 35, and his ferritin level was 618. Transferrin saturation was 27, which was normal, B12 388, folate 5.72. His retic count was 1.1%, and absolute retic count was 33,000. And all the hemolysis and DIC labs were negative. His LDH was 191. And regarding cardiac enzymes, he was having TROPS 46, and NT-proBNP was greater than 70,000. And regarding his VBGs, pH is equal to 7.33. PCO2 was 31.2, and PO2 was 22. His bicarb was 16.4, and urine analysis, regarding urine analysis, his urine contained 1 plus glucose, 2 plus blood, and 2 plus proteins, 1 plus leukocyte esterase, and 11 to 20 RBCs, 6 to 10 WBCs, and 3 to 5 CAST. And urine protein to creat ratio was 2.6 gram per day. And regarding his imaging, when we performed the imaging,
Oh, sorry, Miriam. I think we can actually, let's pause here
okay, yeah, sure.
if that's okay with you, because we have a
Yeah,
lot of information now.
That's a
yeah.
lot to unpack.
Yeah.
Yeah, I'm curious. So let's just start with the exam, Emma. What do you think about, I know there's something on the neuro exam, so
Yeah.
it's different than we were expecting. What do you think about these findings? What does that make you think of?
Um, yeah, I mean, I think the thing that struck me most, there were a couple things. I don't know, did your neuro exam or MSK exam include strength? I'm sorry, I was like trying to write things down and missed that.
Miriam?
Yes. He was having a 5x5 power in the upper and lower extremities.
Okay. Yeah. So I think like the fact that there's no objective weakness is something that stands out. And thinking about our like, inflammatory myopathies more broadly, the fact that he had no rash kind of helps rule out something like a dermatomyositis. Um, and then certainly like the psych exam I found pretty interesting, like this kind of grandiose magical thinking and whether that's more organic or perhaps if there's like substance use involved. And then when you get into his labs, I mean, he's hyperkalemic, which I mean, he's has a lot of things going on, but when I see kind of some of these like metabolic abnormalities, certainly I'm starting to wonder, like, could there be some sort of like drug induced kind of at least subjective weakness and, objective kind of tachycardia and altered mental status or encephalopathy going on. Um, he has a metabolic acidosis, though please don't make me do like Winter's formula or anything like
It's
that.
probably from the kidney issue.
And then, when we were thinking about the swelling and whatnot, I think his hypoalbuminemia kind of helps elucidate some of that. There's certainly more in here to like tease out, but also the fact that like his CK is normal, his LFTs are normal, which we would expect to be elevated as a result of muscle breakdown in myositis, I think is definitely steering me away from any sort of immune-mediated myopathy. So something rheumatologic is sounding less likely. I know someone brought up thyroid disorders as well, which I think could certainly make sense. Someone asked about a vasculitis. It's Sure. I think vasculitis is like one of those things that could always be on a differential. In his case, if we're saying his like altered mental status is secondary to a vasculitis, in terms of like a large vessel vasculitis, he would be fitting more into a giant cell arteritis based on his age, but he's not reporting any kind of headaches or vision changes, which we would associate with the GCA. We haven't done imaging yet, but I'd be, curious if he had any evidence of large vessel vasculitis on like a CT chest. The medium vessel vasculopathies, you've got like polyarteritis nodosa, often can present kind of incidentally on imaging or also with like abdominal pain, which he's not reporting. And then the small vessel vasculitides, yes, that could certainly like cause some hematuria, which he has, as well as his proteinuria. So I think that's certainly still on the differential. Want to think too about kind of lung symptoms. Doesn't sound like he's having shortness of breath, and his lung exam does have crackles, though, non-specific. So would be curious to see what chest imaging would look like in that case. And then, in differentiating like GPA from like an eGPA picture, doesn't sound like he has any eosinophilia on his differential and is not reporting any kind of HE and T symptoms. So it's certainly, I think, a small vessel vasculitis is not off the table, could certainly explain some of his like subjective weakness and weight loss. So I do think it's worth considering. So yeah. Yeah. Jeffrey, thoughts?
Awesome. Yeah, I gave you the hard part of trying to dissect all of this information
Yeah,
that
there's
to
so
begin with.
much.
But I agree, first our thought originally, like, is this a myositis? We're leaning away from that. So then the question is, if this is in the rheumatologic category, there are a couple of different things that I'm going to try to see if I can put together, although we don't really have a time course and he has this, psychiatric issue that's limiting his history. But let's just see if we could combine these together different ways, different patterns we could do it. So one way is we could combine edema with crackles, tachycardia, and his renal dysfunction. And if we combined all those as volume related secondary to his renal dysfunction, then we would ask, okay, what is the renal dysfunction to? And part of that is related to knowing how fast his renal dysfunction has declined. Is this an AKI? Is this a CKD? Um, and we assume that if the swelling has happened over 3 months, that maybe it is a renal dysfunction that's occurring over 3 months. So again, a lot of assumptions here, but we're trying to put the story together without, being told the history. So if it is a 3-month decline, then we're suddenly already in this process that is called a rapidly progressive glomerulonephritis. Why? Because we have hematuria, proteinuria, and we have possibly a renal decline over 3 months. So the things that cause a rapidly progressive glomerulonephritis, there's a couple things that can cause that. Definitely autoimmune diseases are in that bucket. And just as Emma said, out of the different vasculitis that we think of, the ones that tend to cause this renal decline is ANCA vasculitis or the small vessel vasculitis. Pulmonary nodosa sometimes can also affect the kidneys. But we will put that a little bit lower on the differential for right now. It very, very rarely will affect other organs that are above the abdomen, so such as the chest. And I'm not getting a great story that we would typically find with polyarteritis nodosa yet. However, it's still there lower on the differential. So vasculitis is there, small, maybe a little bit more likely than medium at this point. I agree, large vessel vasculitis, we're not really getting a good story for giant cell arteritis, which is a lot more symptoms that are closer to the head, neck, ENT area. What are the other vasculitides that could cause renal dysfunction? There are a couple other ones that are a little bit more rare that we can also think about. So, like cryoglobulinemic vasculitis, and even more rarely things like urticarial vasculitis. But we don't have a skin rash, and we don't have arthritis. So those are other symptoms that we would be looking for to think of those categories. We don't have a neuropathy that we know of yet. So there's other vasculitis that we can think of as well, a little bit lower on the list. And then finally, the other major category that can cause renal dysfunction in our diseases is lupus. Now, when we think about lupus in this patient, the only thing that we really have is renal dysfunction. We do have maybe the psychiatric problem that I'm putting kind of as a separate thing, but if we were to really tie those two together in a patient with lupus, it would be CNS plus lupus nephritis. What's strange about this being lupus is that we have no other physical exam or symptoms of lupus here. Now, some of those can be tricky to see, and because we can't ask a history, it's hard to know. Like, hey, have you had a malar rash before? And he may be talking about his magical, grandiose thinking in response to that. But there are a couple things that we could look on physical exam that are occult that may be easily missed. For example, we can look at his mouth to see does he have painless bleeding ulcers, classically in the top of his mouth. We can sometimes look at his nail folds to see is there dilated nail folds indicating a long history of Raynaud's. But it would be really tricky. At this point, I think that lupus is also pretty low on the differential. So if I were to be given this patient, consulted on this patient right now so far, well, I would be looking at causes of possibly a nephritic syndrome, and I would be working it up from that standpoint. So one of the next steps for a nephritic syndrome, in my mind, from a lab that we haven't gotten yet, is complement levels. And I already said that, probably lupus is a little bit less likely from that perspective, but there are other causes of glomerulonephritis that can be found with low complements. So, and those include things like endocarditis, cryoglobulinemia, sometimes immune complex deposition from serum sickness, or even cholesterol emboli. So that would be another thing I'm curious about. And then I'm also curious, what kind of imaging we would do next. I think that getting a CT chest would be helpful to see what's causing this bibasilar crackles. If it is a small vessel vasculitis, I want to make sure that it's not DAH that's happening. And so DAH, sorry, is diffuse alveolar hemorrhage, which would be something that's really dangerous and could be a sign of ANCA vasculitis. So that's where I am right now. Miriam, you want to continue?
Yeah, sure. So when we did his imaging on CT chest with IV contrast, we found out motion degraded examination in which there were areas of bronchiectasis and calcification in the right upper lobe, which reflected sequelae of chronic infections or inflammatory process. And the second finding was smooth interlobular septal thickening, suggestive of pulmonary edema, and very small bilateral pleural effusion. And on ultrasound, lower extremity veins, there were occlusive deep venous thrombosis in the right femoral vein, right popliteal vein, and bilateral calf veins. And regarding his specific labs, on transthoracic echocardiography, his ejection fraction was 39%, and he was having globally reduced LV function with normal RV, normal valves, and right atrial pressure was 3. On his renal ultrasound, there was increased echogenicity of both kidneys, but with no hydronephrosis. Regarding his complement levels, C3 was 105, C4 was 30, GBM was negative, NA was negative, and anti-double-stranded DNA was negative. Also, hepatitis panel and HIV was negative, and RPR was negative for syphilis, and quantiferon was intermediate, and his cryoglobulins were negative. Also, his rheumatoid factor was also negative. And on pulmonary TB testing, his MTB PCR was negative, and there were 3 AFB smears which were negative, but AFB culture was pending. And I stop here.
Hey, Miriam, can I just confirm the complement levels, the C3, C4, were they normal?
Yes.
Okay, got it. All right, Emma, you want to take a crack at what these labs do and the imaging?
Did you get an ANCA too?
Yes, we did perform ANCA. Should I tell it here or in
You
the next
can, yeah,
alert?
you can hold it off for later. You can hold it off for later.
Yeah, yeah.
Is that because it's going to be positive?
There's a possibility.
Okay, got it. So, um, with all of that, let's go through it. So, with normal complement, negative double-stranded DNA, and a negative ANA, I think lupus is off the table. Would certainly be unusual to have lupus in a 76-year-old male, um, but someone mentioned it could certainly be drug induced, which I agree with, but doesn't seem like that's the case. GBM being negative kind of takes that off the table. When we think about infectious causes, oh, the ANCAs were lost in the lab. Interesting. Okay. For infectious studies, ruling out syphilis. Oh, just kidding. Okay. Um, So ruling out HIV, hepatitis being negative, I think puts PAN lower on the list because it tends to be associated with Hep B infections. Syphilis negative, TB negative. RF can also be, in addition to the cryoglobulins that were negative, RF can be kind of a poor man's cryoglobulin. Um, and then in terms of imaging, the bronchiectasis, it's non-specific. This old kind of infection calcification is, also not super helpful. The interlobular thickening, septal thickening could kind of be reactive in the setting of the pulmonary edema and the mild pleural effusion. So nothing super helpful in there. Certainly no like obvious nodules based on the read that would be consistent with um, that would be consistent with like an ANCA vasculitis or a small vessel vasculitis. They're also, you can't always tell from a CT chest whether there is diffuse alveolar hemorrhage. You really need a BAL to rule it out. But certainly if he was having like a ton of bleeding, we would hopefully see something on imaging. Yeah, and then the bilateral DVTs, I think, helps explain some of the, if not most of the lower extremity kind of swelling and pain, though he, obviously his renal dysfunction is also contributing. So yeah, I think this is helpful. I want to know what those lost ANCAs are. And whether it's a true ANCA vasculitis versus a drug-induced ANCA, I think will be helpful. The echo, you didn't specifically comment on this, but I'm assuming there were no vegetations, because that could, like an infectious endocarditis can also cause a positive ANCA. So yeah, I want an ANCA and I want a renal biopsy is what I want.
Okay, yeah, I'll just see if there's anything else that I can add to the excellent analysis that Emma just provided us with. So, completely agree with everything she said. Essentially, we're looking for other mimics that, besides the rheumatologic disease, besides what we're concentrating on, which is the ANCA right now, that could also explain this. So with the CT chest, yeah, again, yeah, also I'm not sure if that bronchiectasis and the calcification are really saying anything. I guess he's from Northern California, so that could be from coccidioidomycosis, but I don't really see how to put that together with the rest of his case. So I think that might just be unrelated. If we are to think about ANCA vasculitis and it affecting the lungs or the airways, it can affect the airways, actually, the bronchioles, and it can also cause bronchiectasis, although it's probably not the most common manifestation, but certainly it could be related. But then again, we don't have a great history, so we're not really sure, like, over what period of time this has occurred over. So CT chest not going to point us specifically to us towards or away from anything from our side. The DVT is interesting. Yeah, I'm not really sure how to put that together with the rest of this case as something that's like directly related to a vasculitis. Usually, when we think about vasculitis, even though it causes inflammation of the vessels, it's not common for it to cause venous vasculitis and leading to a thrombus. So, Behçet's disease is something that can cause both venous and arterial thrombosis commonly. So is antiphospholipid syndrome. So those are things that could explain that or could tie together. But at this point, I'm really thinking that it may just be unrelated, or it may just be related to the amount of protein that he's losing in the urine. Sometimes you can have a nephrotic syndrome, even though his proteinuria may be a little bit less than what we would expect with like 3 or 4 or 5 grams of protein. But you can lose anti-clotting factors in the urine, and maybe that's the cause of his proximal DVT. So again, not completely sure how to put that part together either. And then from the infectious studies, again, so if we're thinking if this patient has ANCA vasculitis, let's say the ANCA even came back positive, one of the most important mimics that we need to make sure isn't going on is endocarditis. So that's why it's helpful we have the echo, the TTE that shows essentially nothing, no vegetation's there. Now, again, a TTE is not as good as a TEE for a endocarditis, but there's not much else in this history that is necessarily making me concerned for endocarditis being a mimic. For example, there's no murmurs. We're not getting a history of IV drug abuse. We don't have a source of where the infection would come from. So at this point, and also we don't have any evidence on imaging of things like septic emboli. So at this point, I think that's also kind of pretty low in the differential diagnosis. So the complements that we have that are normal are really helpful. Just as Emma said, that makes things like lupus, cryoglobulinemia, a lot less likely. And in terms of the things that can cause rapidly progressive glomerulonephritis with the normal complements, we then think about things such as ANCA vasculitis, good pastures, which was tested and was negative. And then something we actually didn't talk about that I forgot to mention, but it wouldn't really make that much sense in this case, which is IgA vasculitis or IgA nephropathy. Um, so I guess IgA nephropathy by itself can occur alone without the other manifestations of IgA vasculitis. But usually for an IgA vasculitis, which is sometimes also called Henoch-Schönlein purpura, you would get a rash, and that rash is usually very diffuse, and you would see palpable purpura, and it's often very painful, and it often occurs in dependent areas such as the lower extremities, the buttocks, and then it goes diffusely. And we're not getting a history of that. We're not getting a history of inflammatory arthritis either. So I think that's also a little bit down the list. And I think the highest thing that we have, both in Emma and my mind, is could this be ANCA vasculitis? So let's see what happens next.
I
Okay.
know. Can I add one quick thing? Sorry, I know I'm not facilitating, but I just want to. You guys are have so much expertise, so I just want to ask you guys. Like, you guys have mentioned a lot about like ANCA vasculitis. So I'm not saying that's what it is, but you guys mentioned that a lot, and I still don't know if those ANCAs are lost in the lab, but we'll learn the next aliquot. But would there be a certain ANCA vasculitis that you guys would prioritize with this time course? Let's assume maybe the lung and the heart is related to the whole clinical syndrome, which it may not be. Like, is there a certain syndrome you would prioritize over the other?
All right, Emma, you go first.
Yeah, I mean, I guess I would think more of like a GPA given like the lung and renal involvement. versus like an MPA, which I think of as kind of less diffuse. And then given the absence of any kind of chronic sinusitis or history of asthma, like I think eGPA is off the table.
Yeah, I think generally, I agree with Emma. We don't have eosinophilia here, so I would put eGPA almost off the table. If it wasn't ANCA vasculitis, we're not really getting this. So the MPA and GPA can be very confusing and can be difficult to differentiate. But I think the course here, with it just mainly being an acute course, or not an acute course, but a little bit more of an acute course, and it being not affecting the upper airways, if we think of the bronchiectasis as unrelated, I think that would be a little bit more leaning towards MPA, but it could certainly be also GPA. The both of them are possible. Usually, what we think of GPA, if we have the symptoms from the upper side, we would think about things like a recurrent sinusitis or maybe ear or eye inflammation sometimes, and we're not necessarily getting that here. So I guess if I were to guess, maybe MPA. All right, I'm Miriam.
Yeah, should we start? Okay,
Go for it.
okay. So, okay. So, regarding his clinical course, he declined dialysis and he was started on potassium binders 3 times a day with the normalization of potassium levels. And also, we attempted a diuretic challenge with high dose Lasix, but he got a minimal urine output. And you guys were all excited about ANCAs, so here I am telling the ANCAs. So his C ANCA was negative, but his P ANCA was positive, and PR3 level was 0.5, which was equivocal, and his MPO levels were greater than 8. And I stop here.
All right, Emma, you want to take it away?
Yeah, so I think with the MPO and the PANCA, we're more like the MPA range. Someone asked about the CNS involvement with ANCA, and that's really funny you should ask, because Jeffrey and I just had a case like this when we were on consults a couple of weeks ago. A gentleman with who came in with altered mental status and an AKI and was ultimately found to have positive ANCA. I can't remember if it was, I think he was also an MPO.
Yes, he was also
Um,
MPO.
and we really like his entire kind of infectious workup, toxic metabolic workup was negative. And so we ended up thinking that he may have had a like small like CNS ANCA involvement. And something that I learned while working on that case, which I hadn't considered before, is that even if you get like vascular imaging of the brain, like a CTA or an MRA, it's only going to show you medium and large vessel vasculitides. So you can have CNS ANCA vasculitis without anything on imaging. And really the only way to diagnose it is to do a brain biopsy. And for, some unrelated reasons, we ultimately were not able to give him Cytoxan, but yeah, just something to keep in mind, like a small vessel vasculitis such as ANCA will not show up on your like your CTA or MRA.
Yeah, I completely agree with Emma. I think that, the P-ANCA and PO positivity really seals the deal in the diagnosis here. I think the diagnosis being MPA, and I don't think that at this point any of the mimics for ANCA vasculitis need to be considered. This would be a classic syndrome that fits really well with the diagnosis. And I'm proud of Emma for teaching neurological manifestations of rheumatologic disease, which is my favorite topic and a passion of mine. I completely agree with her with the teaching point she just made about small vessel vasculitis not necessarily being seen on CNS imaging. So yeah, Miriam, let us know what happened eventually and what the diagnosis was.
Okay, so our most likely diagnosis was renal limited MPO vasculitis, and you guys were right, and you connected all the dots very well. So our diagnosis was renal limited MPO vasculitis or MPA.
Awesome. Miriam, do you have any teaching points for us? Miriam or Mark, if you have also anything to add, anything that you learned from this case that you wanted to tell us?
Yeah, I'll just say this it was a very challenging case too because of his kind of like some social complexities, I'll say. And I know there was a lot of great thoughts in the chat, about his CNS manifestations, and Emma gave some great teaching points too. I'll say that his just learning more about him, his psychiatric and symptoms have been very long-standing. I won't reveal too much just for HIPAA, but it was very consistent over years and years in terms of his like beliefs and some of these grandiose and magical thinking. So that has not changed at all, like over the last 3 months. So that was thought to be, very stable, and we didn't really investigate that any further. And another reason we didn't investigate that further is because he really didn't want any further investigations. He really believed more in alternative medicine, and when we talked about like what the treatment would be for MPA, and also given the caveat that unfortunately his kidneys were so damaged and probably any treatment would, unclear if it would really benefit him. Like at this point, he really declined any treatment for his MPO or for his MPA. When I went off service, I was just following his chart closely because he was still in the hospital. But it seems like, unfortunately, given his progression of his kidney disease, he became a little more confused and a little more uremic. And then I think the next team that came on still was considering like, should we treat him with pulse dose steroids and further treatment? So then like ethics got involved and everything like that, just to make sure that what he was endorsing was just consistent with his beliefs. And it was thought that like even though he was becoming uremic and he wasn't as oriented as he was when he first came to the hospital, like he just has a very long-standing documented history of not wanting really much medical treatment. So he actually went home on SNF hospice. And he was very happy like with the care that I think he received, and he was very happy with at least a diagnosis. I think that gave him some clarity, but ultimately he just declined any treatment. And it was also he had an intermediate positive Quankold with that right upper lobe bronchiectasis. So we also talked to him about that. Likely, even though it was intermediate Quankold, he does have some pulmonary findings of possible like latent tuberculosis, and he had some risk factors for latent tuberculosis. So even if he wanted treatment, we would need to probably treat him for latent TB first, which obviously would be very intensive and for many months. And he just didn't want treatment for that as well. So thank you for discussing the case, guys.
Thanks so much. Yeah, this was an amazing case, and what an amazing journey that we had. I'm gonna go to Emma. Do you have any final comments that you wanted to say that you enjoyed or learned about this case?
No, I think this was a great case. Certainly a great learning case and fun to work through with you, Jeffrey. Yeah, no, thanks. Thank you so much for having me. I really enjoyed this. Thank you.
Or we're gonna end with animal pre with teaching points. Any? Do you want to summarize?
Wonderful case. Thank you so much for bringing it to the VMR. I have to listen to it again and then refresh my knowledge about vasculitis. So we start with some of the teaching points. The patient came with the complaints of lower extremity edema, and that is something we discuss very often on CP solvers. We localize it to heart, kidney, liver, medications, thyroid. But and a new point which we can talk about is that chronicity of the symptoms in this case. We can differentiate the symptoms on that basis. So if it's mostly acute swelling, we can think about acute decompensated heart failure. Chronic, we can think about nutritional deficiencies, hypoalbuminemia, ultimately localizing it to heart, kidney, and liver. Then we think about the generalized weakness. So generalized weakness can represent anything. It is very non-specific, non-sensitive. It can be asthenia, but it can be myopathy as well. And since this is a rheumatology VMR, so we will think about myopathy. So what does rheumatology take on weakness or myopathy? So they want to know if the weakness or the symptoms, if they are proximal versus distal, if they are symmetric versus asymmetric. And then if the patient says that they have weakness on standing up, we mostly think that it is a proximal weakness. Then we started thinking about some of the differentials we might have because of this myopathy. We can have autoimmune myopathy, and weight loss is a characteristic feature of autoimmune myopathy, which can be due to paraneoplastic or some other causes. Then we have statin-induced myopathy, but this patient, we did not know about the medications he was taking. A statin-induced myopathy can cause proximal muscle weakness. And our differential also included inclusion of body myositis and the immune-mediated myopathy we talked about. But then ultimately, with the physical exam, we realized that myopathy is quite lower on the differential. Then we had that patient had asymmetric pain in the ankles and with pain worsening on exertion, which made us think about claudication. Autoimmune myopathy, which can lead to inflammation plus hypercoagulability, and then inflammatory arthritis or synovitis. Talking about inflammatory myopathy, dermatomyositis was ruled out because of the absence of rash, and the other myopathies were also kind of on the lower differential. Ultimately, we saw the labs, which were suggestive of hyperkalemia, kidney injury, anion gap, hyperphosphatemia, proteinuria, hematuria. So there was a lot going on. If we saw that one by one, it was basically edema, crackles, kidney injury. That was painting a picture of volume overload, in this case, secondary to kidney dysfunction. So is it acute kidney injury or chronic kidney injury? We thought that it was a possible decline in 3 months, and therefore we thought of the possibility of rapidly progressive glomerulonephritis. So what could be the possible causes for that? We think about small vessel vasculitis, ANCA vasculitis can cause that. So mostly we think that in this case, small vessel vasculitis can cause it, medium can cause it as well, polyarteritis nodosa can cause it, but large vessel vasculitis is lower down in the differential. And then things like cryoglobulinic vasculitis can cause it, urticarial vasculitis can cause it too. But then again, there is absence of rash and absence of arthritis. Then we also, apart from the vasculitis, we also thought that lupus can cause such presentation too. How? Because the renal dysfunction can represent lupus nephritis, and the psychiatric manifestations can also represent lupus. So we thought that we should look for some other associated symptoms of lupus, painful bleeding ulcers in the mouth or Raynaud's phenomena in the hands. So we needed a complement level, and we got it. Complement was normal. ANA was negative, double standard DNA was negative as well. So lupus was ruled out. Then we were thinking about serum thickness, cholesterol emboli, endocarditis. We thought that we should get a CT chest to rule out the diffuse alveolar hemorrhage, because that is also one sign of ANCA vasculitis. And we also realized that we need to know if it is true or drug-induced ANCA vasculitis. Then we, what the next investigations we wanted were an ANCA and a TEE to actually rule out endocarditis. Endocarditis is a mimic of ANCA vasculitis. And if TTE is not suggestive, and if the clinical symptoms are very much suggestive, we should get a TEE to rule out that. And talking about the DVT, we thought about the other differentials which can cause it, because ANCA vasculitis is not known to cause DVT that much because of it does not affect venous system that much. So we were thinking about Bisset's syndrome as well, which can cause arterial plus venous thrombi, or antiphospholipid syndrome. Ultimately, at the end, we realized that this is a rapidly progressive glomerulonephritis with normal complement levels. So that mostly raises concerns for an ANCA vasculitis. Which one ANCA vasculitis? It can be GPA, MPA, EGPA. EGPA is lower down on the list because of absence of eosinophilia, so it could be GPA or MPA. And then we also thought that IgA vasculitis, that is henoch-Schönlein purpura, is also a possibility. But there were absence of some other symptoms. That is, there is a characteristic rash in HSP, which was not seen in this patient. So probably a renal limited adult onset IgA vasculitis was also a possibility. But then ultimately we sent the ANCAs and the results came that this was a renal limited MPO vasculitis. And then we discussed that why this patient was having magical grandiose thinking, because CNS involvement is seen in ANCA vasculitis. And in those cases, the CTA, MRA, they are negative. There is negative imaging. So you can't diagnose that on imaging. You need basically a brain biopsy to diagnose that. So basically, ultimately, we got the diagnosis of ANCA vasculitis in this case. Thank you very much.
Thanks so much. Thanks so much for the wonderful case. Thanks, Miriam and Mark. And I hope the rest of you have a great day. Take care.
Thank you so much. Thank you so much, Jeffrey, Emma, and Anmol, Preet, and everybody, and Dr. Mark, and everybody who attended this presentation. And it was very great and you guys have made it so informative. And thank you so much for giving me this platform to present it in front of you. And thank you so much, Dr. Mark. Thank you, and have a very nice day.